Let's welcome our guest for this hour, and this is Dr. Willis Akhwale. He is the chairman of the COVID vaccine deployment task force that was established by the Minister for Health, the Cabinet Secretary for Health, in preparation for the rolling out of the vaccines. Vaccines came, and we're expecting more vaccines. We'll have a conversation about that this hour. We want to say a very good morning and welcome to our audience on KTN Home who are joining us now. You'll be with us for this 1 hour. This is your radio experience on TV. Dr. Akhwale, good morning.
Good morning. Good morning. Thank you, Eric.
Karibu sana. Welcome to the Situation Room. You're occupying a very warm seat for now, but we'll just make sure that we maintain the temperatures. It's cold outside, so it's important that at least we heat it up.
At least today.
At least it's brightening up. Indeed. So, Dr. Akhwale, you the man in charge of the vaccine deployment countrywide. You were appointed by the Cabinet Secretary and the Emergency Response Committee for this. Before we go further into understanding the vaccine rollout and everything, what is your expertise? During this COVID, we've seen epidemiologists, virologists. So what are you, vaccinologist?
No. Let me start by saying my background is a medical doctor, and I specialized in the area of public health, more towards prevention, and in particular, the epidemiology of a very common disease known as malaria. That is the one I've studied up to the graduate level. But my experience spans a lot across infectious disease prevention and control. Within the Ministry of Health, prior to many other assignments, I was in charge of the malaria program. I was then in charge of all infectious diseases, HIV, TB, malaria, including the diagnostic aspects of it. And then I've had a stint working outside of the country, working with the Johns Hopkins University and also University of Washington in many other programmatic aspects. So in a nutshell, this is my experience.
So you understand medicine, you understand Kenya.
Yes.
Tick on both.
And he understands public health.
Public health, which is very important.
Not just from the administrative aspect of it, but from the implementation aspect of it.
The practical side.
Yeah, that one.
Okay. So we'll talk about the vaccines that we're expecting. The president said government is on high gear in terms of procuring the vaccines and getting the vaccines into the country and getting everybody vaccinated. But looking at the first tranche of vaccines that we received, 1 million point something, came into the country, and there was an entire elaborate plan that your task force had rolled out on how they were going to arrive at JKIA, go to Kitengela, go to the various points, be rolled out to the first frontline workers and then everybody else. And then it appears to have just crumbled in the very beginning. First, slow uptake. Then the people who are targeted seem not to be aware that they're actually being targeted. What was happening?
Yeah, so thank you for that question. And this really brings to core what we call programmatic preparations for any major public health intervention. So vaccines, you go through a stage, there's an introductory phase where you are required to put a lot of systems into place before the rollout. Remember, we're also dealing with a vaccine that had only been issued with what you call emergency use authorization. So it does not have full market. Among the requirements is to have a clear system to report any side events. The second thing was to train and capacity build the healthcare workers so that they administer it as is required. And so that is why it took long. And for us, we wanted to learn by doing. So initially, actually, one thing we did not want the vaccines to be lying idle within the stores in Kitengela. So we quickly made a decision that every county must start with one hospital. As we capacity build the other healthcare workers and roll from 47 with an aim of reaching 600. So training was one of the things. And I'm very happy because the training has now borne fruit. Generally, you expect a 10% wastage of vaccines. But because of the kind of training that we really took, we've seen that we have efficiency. We're actually vaccinating more people than the number of doses. And this can be explained that in one vial, on average, you have 10 doses but of AstraZeneca, but you could easily vaccinate up to 12 people. So so that was
10 doses, 12 people.
Is this because of things like spillage, or what are we looking at here? Because it would say, okay, are you giving somebody less than the other?
Explain how the training aspect ties in
Into
with this.
this.
Into this.
Yes.
You see, in training, there are two things you look. You want to train the health workers to minimize wastage. Wastage can come in various ways, including how you draw, and you may not draw the right doses. But also, secondly, is with AstraZeneca, once you open the vial, you must make sure you utilize it within 6 hours. So people must turn up. You do not just open it, because if you open it when you have 2 people, then you have wasted 8 doses. So that's one. Number 2, the manufacturers themselves anticipate wastages. So when you start opening these vials, although on average they'll tell you it's 10 doses, but as you draw out the 5 ml, you may get an extra 1 dose or 2 doses.
Okay.
Although some vials may also miss 1, they may be 9. So that is really how that comes about. And you prepare healthcare workers for that.
Okay.
So you were explaining what was happening at that point. There was a lot of training that took place, and you wanted to roll out and make sure that you're optimizing efficiency.
Yeah.
And so you say that you're very happy because we actually have more people seeking to be vaccinated than the vaccines that we had.
Yes.
And so what was our wastage percentage? Did we waste any?
At this point, we are actually on a gain. It could be anything about 5%, the last I looked at. Because by last week we had got 1.5 million doses overall. And with 100,000 doses still, we had almost vaccinated 1.5 million. But let me also say something about healthcare workers, because that was stated as an issue when we started the vaccination. The truth of the matter is, with only one facility in a county vaccinating, and healthcare workers spread all over, some working in remote areas, access was already a challenge. And many of them were waiting for the vaccines to be delivered to the lower posts. You know, they will not spend their fare to travel and go to Kakamega from some remote area to get that vaccine. And obviously, we had assured them that we are going to roll down slowly up to what we are calling level 3 facilities. But because of the global constraints, and when COVAX started indicating to us these vaccines are not there, then our plan became affected. That was one major challenge that we got. That what had been promised to us, very close to almost 3.5 million doses between March and May, did not happen. The second thing that had an impact is that, if you remember, in early March, the country experienced the third wave. It was very severe, especially the first 2 weeks. And we had to make a decision that now we are no longer just protecting the frontline workers whom we are vaccinating, but we must protect those at most risk of infection, severe disease, and death. So we made a decision when we looked at the data. We had to bring in now the 58-year-old plus to be vaccinated. So that actually meant, if you look at our population statistics, the over 58 are something like 2.7 million. So we had planned to vaccinate 1.25, but we quickly had to start to bring in another 2.7 million Kenyans.
The uptake initially seemed to have been poor. Because, I mean, beyond what some of the factors that you've already just spoken about, there were these rumors swirling that, are we sure that what we are taking is authentic? Why should we? Not just coming from the wider population of Kenyans, but even coming from some health workers in some quarters. And so that sent a lot of the rumor mill then was spinning very quickly. How did you deal with that in terms of communication? Because in as much as, you dealt with, or you still deal with the implementation, the communication is a vital factor here. How then were you able to deal with that, and how will you continue dealing with that going forward?
Okay, thank you. From the beginning, we faced that challenge of misinformation, rumors, call them untruths, a lot of them through social media, some even through main media, because people would talk and tell you that these vaccines did not go through a complete evaluation. We don't know what it may cause. But also, even on the ground, there were rumors that, this thing is all family planning and everything like that. So one of the things we did at the task force was to recommend what we call frequently asked questions, develop them and give answers, share them as widely as we could to do that. But we also strategically said we need the leaders, the political leaders, to champion this, because people listen to them. And we also listen to people, and we realized they kept asking one thing: if the president is not vaccinated, I'm waiting for that. That is when I'll trust. This thing, I'm not trusting it until I see them. And fortunately, and with that wave, then His Excellency the President, the Cabinet, the governors and the senators started
Chief
this
Justice
public.
as well.
And if you look at our statistics, I think that was on a Friday. Monday, the following day, the uptick just shot very high. So that is something that worked for us. And for us, I think the use of political leaders and other leaders of influence, they could also be in the business, the religious leaders, is very, very key. Let me also mention, we met the religious leaders under the Interfaith Forum. I remember that day it wasn't a very easy conversation, but we really gave them all the information. They wanted a lot more, and we are going to continue really working with them. So use of leaders, both political, the religious, business, and other community influencers is going to be very key going forward.
Sure.
Dr. Akhwale, why was it not an easy conversation?
Let me say, in one of them meeting with the religious leaders, the Catholic Church in particular, they had some of their medical doctors, and they were taking this point of view that we really do not need to undertake mass vaccination. They had a lot of questions about it. They were saying it's not going to be useful at the moment. So we had to go into the science and come back to a decision public health impact. I know, in fact, at the end, what I was told in that meeting is that, yes, you've done very well, but there are still those who are convinced this requires. However, the good thing is that when the Catholic Church decided to do the uptake themselves, the vaccination, you saw Bishop Muheri and others, then really that solved a lot of questions that had been asked.
Which takes me back to that point, the initial point of setting up systems and planning. Had you not factored in the issue of stakeholder engagement and the importance of stakeholders in rolling out a campaign such as this one? Stakeholders, number one, being the political leadership, community influencers, like you're saying, religious leaders, healthcare workers themselves. We were speaking with the Secretary General then of the KMPDU, and you were saying, we haven't even been called by the task force to be told exactly what the plan is. Had you not factored this in?
Let me say, there are two aspects to this. First, stakeholder engagement. Remember, during the first phase, it was targeted. It was healthcare workers, it was frontline workers, the security forces, the teachers. Those as the very key stakeholders, because we are not going to a full-blown campaign initially, but we planned to move to that come July. So this is the time we'll be going to a full-blown campaign, because it would be covering almost the entire population. But looking at key stakeholders, the first one was the Council of Governors. We had meetings. We had meetings with the CECs. We had meetings with the governors themselves. Then we had meetings with the teachers. We had meetings with the union teachers. For healthcare workers, we really had a lot of virtual meetings. One of the things, you see, we were in an era, and during that time there was a surge. We were not having physical meetings, so we were not having any hotel meetings. But if you really go and look at our records, we held virtual meetings with very many healthcare workers. I did a lot of presentations. Virtually every 2 days at 7 p.m. to 9 p.m., I was talking either to the doctors, the nurses, the other health professionals. So, but we appreciate that, you know, we are moving from the culture where it's until I'm called to this big hotel and I see and I am...
if I'm not recognized.
Yes.
So this was among the risks that you saw in the rollout at that point. And then there was now the whole issue of the slow uptake, and then, like you say, once people started seeing their trusted influencers going ahead to take it, then there was a wider rollout. But then there were people who were not initially in this first group. They are not among the elderly who still accessed the vaccine. How did that happen? Is this a leakage in the system, or was it just one of those that you said, okay, it's a good thing because everybody wants to get a vaccine?
Yeah, in times of scarcity, you'll put rules. Even if there is hunger and you tell people that we want to feed the children first, you'll still get other people coming. But the experience with the vaccination programs, one of the cardinal rules from experience is that you should never be very restrictive. Because if you're very restrictive, you could put away people from coming when you need them. And remember, everybody has to be protected. So that is one guidance. Number two, as I told you, there's this issue of wastage. So in a remote area, you've opened a vial, you need 10 people, 2 people have thrown, then you have to make a decision between discarding 7 or using it to somebody who's rushed up. Then the other thing was, this age of elderly was quite a challenge because it is 58, but there are so many 56, 57 who, remember during that time there was a surge. Hospitals were full and people could see. So this 58 as a line became a challenge, and that's what you keep seeing in our statistics, others. If you really look at many others, they're actually between 55 who feel I'm as good as 58. I did this vaccine.
Sure. Doc, I'm still stuck on this communication issue. And one of the major things now, a lot of people, and we're not just talking, it's across board, who right now don't understand the importance of getting this vaccine. Even as you work on the implementation, clearly from what you've told us today, it is something you understand in the implementation of prevention of diseases. What is it that we are saying to Kenyans now in terms of that communication? Because the communication that seemed to come out was the vaccine is here, come out and get it.
Yeah.
But there are people who are asking questions. Okay,
Why?
What does it do for me if I get it?
So let me really admit here, and it's been a very fair criticism that our communication was not really up to what it should have been. We agree that during that phase, that's a lesson we've learned. And now during this second phase, one of the things is we've brought in now experts. So we've recruited a communication firm. It's already started working with the Taskforce to start really drilling the messages, targeting which messages need to go, trying to make consistency in the way the messaging is done. So we will be seeing an improvement in that. Not really to say as an excuse, but during the first phase, one of the challenges, as I've told you, when we realized the vaccine are not there, we had this to balance between ramping up communication, yet people show up and there are no vaccines.
Yes.
So there was that balance that let's not talk too much and then people turn up and yet you have no vaccines to give them. Yeah.
In the room, you have Eric Latif, Nduo Kosi Muga, and our guest this hour is Dr. Willis Akhwale. He's a chairman, COVID-19 Vaccine Deployment Task Force, talking about vaccine deployment in the country, the lessons learned, and the importance of getting the vaccine, and what you should know about this. So, Dr. Akhwale, you'll tell us about, the vaccine doses that we expect in the country. You'll also tell us about the different vaccines and whether one is better than the other. Is it the Indian? Is it the Chinese one? Is it Sputnik 5 from Russia? Is it Johnson & Johnson? Is it Pfizer? Is it the UK version of AstraZeneca? But let's start with, why is a vaccine important?
A vaccine is very important. First, from the experience we've had with the impact it has on a number of diseases that may have killed more people actually than actually COVID has done. TB, for example, was a major killer. Measles was another major killer. Mumps and pertussis and whooping cough, all these have been brought under control. Polio, obviously, is another one because of vaccines. So when COVID struck and scientists started looking at the best options, obviously hygiene measures, physical distancing, based on the experience of the Spanish flu of the 1918-1919, came in handy. But we had one thing in our advantage, that technology now had moved to make it easier for us to develop vaccines, because now we have better molecular understanding of the pathogens. And many people have been asking, was this thing rushed? The truth of the matter is that in the last 10 years, there's been a lot of research in what you call platforms that can then be used to develop vaccines. And in particular, a lot of work had been done towards getting a vaccine for Ebola. So based on that, it was easier for researchers to ride on that. And that's why these vaccines came faster. And for us, it was very crucial, because the first thing that was identified in the clinical trials is that these vaccines were able to stop severe disease. Remember, COVID was killing. It was very unpredictable. Somebody gets it, and within no time, there are those who die very fast. So severe disease was the biggest challenge. You had to stop the deaths. So that is one. And for me, that is the biggest utility now. And the reason that they were given emergency use was to protect lives. That had been shown to occur. So that is number one. When you use a vaccine, you are protecting yourself. You will not get that severe disease. I mean, you are not going to be among those people who have to start looking for oxygen, being in an ICU bed, spending many days in hospital, being isolated, completely bringing you down from your norm. So that is number one. Number two, in a number of countries now, as they started vaccinating, they started seeing an impact in what you call transmission between communities, what you want to call mild to moderate disease. And many of what you hear, the efficacy, is basically determined by that. Let me say that when it comes to severe disease, in the clinical trials, all the vaccines were 100%. They stopped severe disease. So if anybody asks you which vaccine is better, the vaccine that is good is the one inside your arm, already protecting you. And usually 2 to 3 weeks after vaccination, your body has thrown an immune response to start protecting you. The figures that you hear, 70%, 92%, is a lot more what we want to call epidemiological parameters. And they can vary from one region to another. You could get a vaccine that is evaluated where the incidence of COVID is very low, or just before a surge. For example, if there was a vaccine evaluated in Kenya November, December last year, you may not get the same as if it was evaluated in March. So those common parameters have never, so there has not been a head-to-head comparison between these vaccines. But it will also be exciting if you reduce the so-called symptomatics, the mild and moderate ones, because then you start getting fewer people getting sick, you start getting fewer transmission, and you start getting people back to their normal life, socioeconomic life. And for a country like Kenya, and the whole globe, the economy is suffering, the loss due to lockdowns. Obviously, when numbers go high, when there's an increase, we go to lockdowns. So one of the things vaccinations are going to do, and the reason the government is investing heavily in vaccination, is that we want to reduce any chance of going to lockdowns, and we know the impact they have socioeconomically.
Okay. How much of it is a challenge, though, even as you're saying these things, even as I, for example, am demanding communication that is very clear to the people, when you don't have the vaccine in terms of the numbers, then it becomes very, very difficult to essentially do your job, Daktari. That to say, this is the communication, this is what we're asking people, this is what we are saying in terms of what a vaccine can do for you. But in the last 6 months, since we were sure that the vaccine would be rolled out, we've gotten 1.5 million doses against the population, hopefully to have vaccinated the entire adult population by a certain time. That's a challenge, obviously. Now, we've been told that over the next 2 months, around about 23 million vaccines then will be made available. That's what we've been told. How do you feel about that? And are you sure that then this communication that you would essentially be rolling out will be backed up by actual implementation of the thing, being the vaccines being in the country?
Yes, that is a challenge we've taken. First, let me say, myself and the task force that I lead, that really has representation from many sectors, is excited with the fact that now there's an improvement in the global supply of vaccines. We started seeing that, especially after June, we'll be moving from scarcity and getting better supplies. Yesterday, we had a meeting with the COVAX team, and they actually affirmed that. And therefore, when we look at the pipeline for Kenya, we do see that, especially in the next 2 or 3 weeks, we are going to get the US donation of 1.7 million doses of Pfizer. We have also been told under the COVAX, we get 270,000 doses of Pfizer as well. And then, the government actually placed orders for Johnson & Johnson. It's only that the manufacturing, it was a constraint. When you hear that countries were hoarding, really what was happening is that many of the rich countries had booked supply. So even if you had money, you had to wait on a queue.
You join a queue.
So the government has placed order through the African Union of initially 10 million doses, but there's been a price reduction. So we will get 13 million doses. We've been told the delivery will start next month. We are already in discussions about those deliveries. And when you see with 13 million doses, we are estimating to be getting 1 to 2 million vaccines per month. In fact, as a task force, we are preparing for the increased doses and also preparing for multiple vaccines.
Okay.
Because now we are not going to only have AstraZeneca. In the next 3 months, most likely, AstraZeneca, Pfizer, Johnson & Johnson will be in this country.
Okay.
So what will you be telling people? Do you have a choice of whichever you want? If you want Pfizer, go to this facility. If you want Johnson & Johnson, go to the other facility. Or do you just present yourself to a facility? Ile utapata ndio utadungwa.
Yes, this was an interesting discussion 1 week ago with the task force, and we were learning experiences from other countries. And what we really said is, all these vaccines are good. So that's number one. Number two, many vaccines have short shelf life. From manufacturing to use is 6 months. But when you put logistics there, you'll find by the time they are really reaching the end user, they most likely have 3 months to expiry. So you need to use them fast. So first strategy. We actually made a decision that we want to allocate vaccines to a facility. So if Kenyatta Hospital, we decide it is Pfizer, it's Pfizer. Mama Lucy, we say it's Johnson, it's Johnson. If we say Embu Hospital, it is AstraZeneca, it is going to be AstraZeneca. So that when you go there, it's not like you are walking in a kiosk and saying, mimi ni mandazi na chai, mimi nataka hii. Because you can see the challenge you may have if people say, I only need Pfizer. If it is not there, then I'm waiting until you bring it.
Yeah.
But will that capacity also not be determined by the very facility's capacity to store these vaccines? Because some of these vaccines have to be stored at rather unusual temperatures, wouldn't you say?
A very good question. And actually, even before I came to the studio, because we are now talking with Pfizer, and those ultra cold chain requirements for some of them require exactly that. That is why, as a task force, our recommendation is, especially for Pfizer that requires that specialized cold chain, we are going to really prioritize level 6, level 5, and a few select level 4 facilities. Okay. While those that require 2 to 8 will go down into level 2, and most likely also we'll be using them to reach the communities through outreaches. Because during this time, we are not going to restrict ourselves. We are scaling up. We have to reach 10 million people. We want to reach herd immunity in the shortest time possible. So we are going to change strategy. In fact, we've been only using 200 of the 600 facilities because of the constraints we had. We are quickly going to expand to use all the 600 facilities, add more, but also start doing outreaches. So one aspect that we have brought in to help better planning is the Chanjo system, the digital platform that was developed by our own people here in Kenya to support this. It has a self-registration module. So we are going to encourage people to register in it, book the date, the place when you are going to be. Once you've done that, we'll be able to project. So we will know this number of people have applied to get Pfizer at Kenyatta National Hospital, and we are only able to send those number of doses that will be used within a period of 5 days.
What about those who don't have access to the internet, for example, and would like to get this and are not able to get onto this platform? How do they register?
So two things. Through the same module, we have what we call assisted registration. So you can assist others to register on it as well. The other thing you can do is that you can also go to the nearest health facility, get registered and come back. But more importantly, last week, the Taskforce made a recommendation on what is called USSD, where we could use even community health workers to register people from within communities and then come to a vaccination post when we have an outreach. Yes.
So the idea here is you go to the portal, you book an appointment
Yes.
for when you want to go and get the vaccine.
Yes.
And then this is, the assumption here is that it will work so seamlessly that it's able to actually lock out and say, okay, this particular day we have X number of people who are coming to KNH. It's not available for you. Pick a different date. This is the assumption that we're making. Because if I just go onto the platform and I say I want to go on the 15th of August, and everybody picks the 15th of August, and then I go on the 15th of August, people expect, if I booked an appointment, surely I'm coming to get it. Not to come and be told, unajua watu ni wengi, ama hazijakuja, MOH haijatoa. How do you address those?
That is where we want to reach. That's the ideal. But obviously, it's not going to be that straightforward. But let me say that even in the first phase, we tested our self-registration module. So far, over 200,000 Kenyans have actually self-registered for vaccination. We did not really popularize it because we knew the vaccines are not there. People would have been frustrated registering and missing them. But going forward, as I've said, we are now going to have adequate and an increasing number of vaccines. So we really want to make use of this self-registration. It may have challenges, but we'll be making it better and better. One of the challenges we've had, remember, others health services must continue.
Yes.
Remember, vaccinations for children must also continue. Remember, this vaccination post is where we go. We don't want others to be selfish that COVID is killing us, vaccinate me, and we are not vaccinating the children against measles and TB. So we will. That is why we are working with county governments in particular, because that's where vaccination takes place, to start seeing how we best schedule. One of the directions we've given is that any post, we are not going to interfere with childhood vaccination. It must be away from where the MCH clinic is. And really looking at the capacity of each facility, if it has 2, 3 nurses, clinic officers, and doctors, then you are able to see how many. This determination is part of what we are calling micro-planning that the national government is doing with the county government. It started last week. A tool has been prepared. We are going to be able to know how the kind of workload any facility can take.
There's something I'd like to ask, Daktari. You are a public health practitioner. Now, I don't want to be a soothsayer, neither do I want to be a prophet of doom. But if COVID has come, something else will come. Before COVID, we had HIV. Now, public health practitioners such as yourselves focus on, if I get it right, the preventative aspects of healthcare. Now, within the healthcare system, there's a cadre of employee called a health worker, community health worker. Now, with the HIV pandemic, very many people were trained in this field. And a lot of the success that we've had in the field of HIV can be attributed partly to the work that these people did. Now, my question, what did the ministry, maybe I'm going outside the boundaries of the task force, but this is a workforce that exists. This is a workforce that is trained in counseling. This is a workforce that is trained actually in communicating. If you tweaked that information from HIV to COVID, would this workforce not have been useful? So my question is, do we always use the human resource we have to ensure that, one, we communicate these messages that we want to communicate, or that when it comes to preventative aspects, we also get them to reach out to the communities in which they live because they exist?
Absolutely. Now, let me say we are going to use them. In fact, the planning that is going on now is now to really identify them Remember, from one county to another, there are different numbers. They are identified a little bit different, but you are right. A lot of investment has been put into community health workers. They have been very useful in malaria, which is my main field, in HIV, in tuberculosis, tracking people who have not come. Right now, even those who may get the first dose, and we start looking for them, we want them to be fully vaccinated, you really have to follow on community health workers. You have to work very closely with others. But community health workers are very, very important. And that is why, to us, this next phase of accelerating vaccinations, they are going to be at the core. They are the ones who will be at the core of community mobilization, what you call defaulter tracing, messaging, as you are saying. They are going to, and even reporting. Because, like even right now in Western Kenya, we have reports of surges of COVID. And, health-seeking behavior can be different. There could be a lot of deaths within community. You depend on people like this to start giving you that information. You depend on provincial administration, those who are issuing the death certificates. And you start figuring then what is really causing, how come now we have more deaths at this particular time. So I appreciate the issue of community structures. They are very key in prevention. And yes, for COVID, a highly infectious disease, the principles remain prevent, prevent, prevent.
When you say that, it sounds very good. It sounds the task force has put in the thought behind it and the measures and the plans behind it. But just judging by that first phase, where can you say that you were able to actually train and use community health workers in vaccine rollout, so that then you can say the next 23 million doses that we expect, or so many millions by the end of the year, community health workers are going to be central to the rollout of vaccine?
Yes, let me clarify something, and I said it at the beginning. The very first phase was highly targeted. We knew where teachers are. We knew where healthcare workers are. We knew where security forces are. Now, the 58-year-old, of course, that's what brought the general community. But it was an interesting observation that their demand, because they saw the impact of the third wave, they came. I was looking at statistics for a county like Kajiado, where the number of health facilities were few. So the uptake was very low until we allowed 58-year-old. And Kajiado was among the top 10 in terms of uptake, because, that is where a lot of our people live. So they came in huge numbers. Now that we'll have enough vaccine is when we are really going into a campaign mode. Now is when we are going deep into the communities. We are now targeting every adult, because the vaccines are only registered for use up to 18. Pfizer, I think, may be registered up to 16. But our main target first is to really ensure the adult population who are at most risk of severe disease are protected. So, yes, we had planned to use community health workers. We did not use beyond reasons beyond us that the vaccines. We expected 3.5 million doses, you can imagine. And we've struggled to get 1.5 up to just last week.
So what plans do you have then to get the community health workers ready? You say in the next 3 weeks, we are expecting so many doses, millions of doses. Are the community health workers already being trained, already being deployed?
What I actually said, and this is ongoing, we started working with the counties last week on a Wednesday to develop a micro-planning tool that identifies, among the things we want is to use those community healthcare workers. So by this week, I expect the trainings have actually started, but of the TOTs, the county, the people who will now go and work with the county teams to do that. That has started, I can report here.
Where I was going with my question is beyond COVID. A lot of the burden that our healthcare system has is because of the curative approach we have to healthcare. So COVID aside, surely practitioners such as yourself with the wide experience that you have, should we not push for a policy where, if you recall at a younger age, we used to have these extension workers. Now, what they did, they lived among the people, and what they did was this education we keep talking about, sensitization, they did a fairly good job of it. And right now in this day and age, and with the burdens that we have, should we not focus on getting these people to be part and parcel of the healthcare system in a way so that even if there isn't COVID, these diseases people don't even need to accommodate, don't need to have, are eradicated because it can be eradicated, so that even the problems we have with people needing healthcare at health facilities is reduced significantly.
Like malaria.
Yes.
Absolutely. And for me, I've seen the utility in malaria control. It's good, it's amazing. So, but let me say that I think the issue of sustainability of community health workers has been also on the aspect of their remuneration. But in the last 3-4 years, a lot of county governments have put in resources to start supporting them because they need to travel. There's work they are doing. We must invest in them and in a sustainable manner. I agree with you, that is what will strengthen. The focus of the ministry, for sure, I sit in senior management. I know the Cabinet Secretary, Mutai Kagwe, makes it very clear that it is prevention. This is where our focus should be. But we must then work very closely with the county government because prevention will begin at the community level. So policies that support counties to implement preventive measures is now a major focus at the Ministry of Health.
What do we need to do to get back to those good old days that City is talking about, when we had health and Girigasha? People who are just common in the community.
Yeah, there is a lot. Devolution of health services in a big way was also aimed to do that. Because you see, when you enter the community, you are the one who sees what the burden is. You are the one who sees where the breeding of mosquitoes are. You are the one who sees where the dirty water is and what you need to do to that. So that focus at the county level, very clear strategies that can be implemented in a sustainable way and making use of the resources you said. Once you start asking how many community health workers Kenya has, you'll get very varying. It's a big time. We realize it's a huge army that can be used and put to very use utility. So for me, I think it's going beyond policies and putting in sustainable structures and looking at health just beyond feeling well, but a major contributor to the socioeconomic development of this country.
We have been having a conversation with Dr. Willis Akhwale. He's the chairman of the COVID-19 Vaccine Deployment Task Force. Good morning.
This is the Situation Room, the only way to start your day.